Poseida. Poseida offers the next generation of cell and gene therapeutics with the capacity to cure. And there are a couple important statements there. One is that we actually have very differentiated technologies offering next generation of both cell and gene therapeutics. And also, we aspire to have long-term durable responses both for the cell and gene therapeutics, and in fact, try to have the capacity to cure. Moving on to the overview of slide 3, Poseida Therapeutics was actually founded as Transposogen Biopharmaceuticals almost 20 years ago. Transposogen was a leader and pioneer in the genetic engineering space, and in 2015, we decided to spin out Poseida Therapeutics. Poseida is headquartered in San Diego, California. We now have over 150 employees, and we've raised approximately $400 million in funding to date. Importantly, because we're not a startup, we've been around as Poseida for more than 4 years, and before that, an additional over 10 years as Transposogen. We have very broad, very powerful platform technologies, and all of the key technologies have patents with claims issued. You can see on the right that we have a very experienced management team, including myself. I was an MD PhD candidate at the University of Pennsylvania, also did residency and fellowship in clinical pathology, and was actually the very first graduate from their gene therapy program. Next slide, on slide 4, you can see that this main story you'll see here is that we have extremely broad and extremely powerful gene engineering technology platforms that allows us to succeed both with cell therapies like CAR-T and also with true in vivo gene therapies such as liver-directed gene therapies. On the cell therapy side, we have some very significant differentiation in both the autologous CAR-T space and now in fully allogeneic CAR-T. Importantly, everything I'm going to show you in this presentation, all of the platform technologies are wholly owned, and all of the product candidates in our pipeline are wholly owned and currently unpartnered. Again, the key story is that we have very broad and powerful platforms that allow us to make really product after product in both the cell therapy space and the gene therapy space, as well as do out-licensing to create additional value. Slide 5 is a summary of our very broad platform technologies, and it's actually difficult to get every technology on a single slide, but this is our attempt. And you can see here that it's divided into 4 categories. First of all is the non-viral gene insertion technology, and here we have our own proprietary technology called Super Piggyback. Piggyback is a DNA transposon. It's not a viral system, and we have souped up or made a hyperactive version of this called Super Piggyback. Importantly, Super Piggyback is an extremely efficient technology to insert DNA stably into the genome. So for example, with our liver-directed gene therapies, we believe we can take a transient therapy and make it into a single treatment cure. Moving on to the gene editing technologies, we have 2 separate platforms. One is called Cas-CLOVER, and the other is Tal-CLOVER. And you can see the common enzyme between these 2 systems is what we call CLOVER. CLOVER is an extremely specific gene editing enzyme that displays no to very low off-target activity. In fact, we've now done millions and millions of sequence reads, both with unbiased and biased sequence analyses, and we've never seen a single unwanted off-target site above background, making this, we believe, the cleanest gene editing technology in existence. Either one of these technologies, the gene delivery piggyback technology or the gene editing Cas-CLOVER technology, works very well and easily in any cell ex vivo or out of the body, such as T cells or hematopoietic stem cells. However, they also can work in vivo in different tissues in the body. And in fact, they both work in every tissue and every cell type ever tested, both dividing and non-dividing. But if you want to get it to a specific location in the body, you need to package these in an additional technology, and that is the gene delivery technologies. Here we have 2 separate technologies. One is the latest, greatest AAV vectors, which we've in-licensed from Mark Hayes' lab at Stanford. And the second is our own in-house nanoparticle technology. The current therapeutics that I'm going to show you in our pipeline are using AAV to deliver piggyback to the liver. And in that case, AAV will get your therapeutic transgene into the liver cells, and piggyback will then integrate that into the genome, making it a single treatment cure. The longer-term goal for the company is to switch to a completely non-viral nanoparticle technology, which enables additional advantages. And then lastly, highlighted proprietary tools. These are generally tools that are specific to the CAR T space. And two of the most important for us are the stem cell memory manufacturing platform. TSCM is a true T stem cell. It's a highly desirable population of cells that can be used to improve your CAR T products, and also the booster molecule. The booster molecule is used to increase the yield in manufacturing of our fully allogeneic CAR T products, to the point that we can now make literally hundreds of doses from a single manufacturing run, thereby decreasing the cost of CAR T to the range of a monoclonal antibody. The next slide 6 is a summary of the piggyback DNA transposon technology. You can see on the panel on the left that this is a really simple two-component system. You have your piggyback DNA transposon, which encodes and delivers your therapeutic transgene, labeled here as cargo, and you have a single enzyme called the transposase. That enzyme works extremely efficiently to grab that therapeutic transgene, that cargo, and cut it out of your episome or your plasmid and then stably integrate it into the DNA. This is a very easy-to-use non-viral system, and it has a very large cargo capacity. People have delivered more than 200 kilobases of cargo using the system, which is about 20 times larger than the viral lentivirus or gamma retrovirus systems. Importantly, this works in a wide variety of cell types. This works in every single human cell type, both dividing and non-dividing, ever tested that we're aware of. And importantly, that includes resting T cells. If you can do your transgene delivery in a resting T cell, you can create a CAR T product that has a very high percentage of this desirable stem cell memory phenotype. It also offers multiple safety benefits when compared to viral technologies. For example, when it integrates into the DNA, it is non-mutagenic and non-oncogenic. The Cas-CLOVER technology shown on slide 7 truly is the best of two different worlds. One is the ease of use, ease of design, low cost, and multiplexing ability that one could get from the CRISPR technologies. But unlike the CRISPR technologies, this enzyme, CLO051 or CLOVER, is extremely specific, so you don't get unwanted off-target mutations. Importantly, this technology also works in resting T cells, and so you can create fully allogeneic CAR T products that maintain the desirable stem cell memory characteristics. And also importantly, we invented this technology, we have patented it, and we now have patents with claims issued. Slide 8 is a demonstration of using the piggyback technology in the body, so in vivo gene therapy, to get single treatment cures. And in order to do that, we need to package the piggyback DNA transposon and the DNA transposase inside of AAV, which is shown on the left-hand side of this panel. Eventually, we are going to move to fully nanoparticle delivery to eliminate the virus entirely, which creates additional advantages. On slide 9, you can see the power of combining the various gene editing technologies, such as the Cas-CLOVER technology, the piggyback DNA modification technology, and either the nanoparticle or the AAV delivery technologies. By doing so, you can achieve competitive advantages in every single area on this space, including not just what we've focused on over the last several years, which is CAR T for oncology, but also having solved now some of the toxicity issues with CAR T and also cost issues with fully allogeneic CAR T, we can use CAR T outside of oncology. But furthermore, we've actually shown that we can do genetic modification of induced pluripotent stem cells, hematopoietic stem cells, We can do regenerative medicine and in vivo gene therapies. Longer term, we plan to structure the company in a way that will allow us to maximize our value by either spinning out companies around different therapeutic modalities or simply selling or out-licensing certain therapeutic modalities. On slide 10, this shows you our current cell and gene therapy pipeline. These are the products that we are keeping and developing in-house. And again, we have complete worldwide rights to all of these technologies, and these are currently unpartnered. What you can see on the top of the slide, which is our CAR-T programs, is an iterative approach to indications. So for example, with multiple myeloma, you can see our lead therapeutic, BCMA-101, is currently in a potentially registrational phase 2 trial, which is also in an expanded phase 1 trial. But we're already progressing BCMA-ALLO1, which would be our fully allogeneic version targeting relapsed refractory multiple myeloma. And the IND for that program will be late this year or early next year. And we already have a follow-on to that product, which is a fully allogeneic dual CAR program, which includes both BCMA as a target and also CD19 as a target. And the IND for that program is next year in 2021. Likewise, for prostate cancer, our first program, PPSMA-101, is an autologous CAR-T, which is currently in the phase 1 clinic. We also now have a follow-on fully allogeneic version called PPSMA-ALLO1 with an IND targeted for 2022. Also in the solid tumor space, we have a very exciting target called MUC1C. MUC1C could potentially allow us to treat multiple different solid tumors that are derived from epithelial cells. This includes a very long list, including breast cancer, ovarian cancer, pancreatic cancer, colorectal cancer, lung cancer, and many others. This, based on the strength of our allogeneic program, will be a fully allogeneic program right out of the gate with an IND in 2021. However, we already have a second-generation version of this where we have MUC1C and another undisclosed target in a fully allogeneic product with an IND in 2022. And then last but not least, in the CAR-T space, we also are launching a fully allogeneic dual CAR for the B-cell lymphoma and leukemia space where we're targeting both CD19 and CD20, and this product will have an IND in 2021. And finally, on the bottom of the slide, these are our gene therapy programs, in vivo, liver-directed gene therapy, shown in orange, with the lead program, POTC-101, targeting ornithine tricarbamylase deficiency, and a following program, PMMUT-101, targeting methylmalonic acidemia. Next, I'd like to introduce our immuno-oncology and CAR-T programs in greater detail. And on slide 12, you can see one of the key differentiators to all of our products is that they are comprised of a high percentage of highly desirable TSCM cells. TSCM, or stem cell memory T cells, are the true T cell stem cell. These are the self-renewing, long-lived, multipotent cells that give rise to all of the other T cell subsets, including the central memory cells, effector memory cells, and effector cells shown on the right-hand side of the slide. It's now known in the field of immunology that this is a one-way unidirectional differentiation pathway. It is the cells on the right-hand side of the slide that actually do your killing, and so that is best thought of as your drug. The TSCM cells is best thought of as a prodrug, and so this is a special prodrug that will go into the patient and graft in the bone marrow and graft in the lymph nodes and create potentially unlimited amounts of drug. Therefore, we are offering prodrug version of CAR-T. This results in a lot of potential benefits. One is both we and others have now seen a very strong correlation with best responses and the amount of stemness in the product in our clinical trial, and others have seen the same thing in their clinical trial. Also, this results in slightly more gradual killing, which results in much less toxicity to the patient. We have never seen a patient who needed to be admitted to the ICU. We've never had a patient with bona fide neurotoxicity, and we have less CRS. This enables fully outpatient dosing, where we can dose a patient, they can go home, and unless they spike a high fever, which is uncommon, or unless they need labs, they would never come back to the hospital. Importantly, These cells, because they can live so long, have predicted better duration of response. In both humans and we think in certainly animal models, we have seen the ability to re-respond without re-administration of the product. Lastly, we think this is an important key to CAR T success in solid tumors. On slide 13, on the left-hand panel, you can see how we create and maintain a product with a very high percent of TSCM. And this starts with the piggyback non-viral delivery technology. Piggyback preferentially transposes and inserts your therapeutic transgene into the highly desirable TSCM population. In contrast, the lentiviral and gamma retrovirus technologies are almost completely excluded from this cell population. If one is then going to make a fully allogeneic version of your CAR T, you have to do either multiplexed or multiple rounds of gene editing. Cas-CLOVER, unlike a lot of other technologies for gene editing, works really well in resting T cells, and therefore you can maintain and preserve this stem cell memory population in a fully allogeneic product. Importantly, Poseida was the first company to figure this out back in 2015 and 2016. We were the first to file patents in this area, and we now have very strong patent position covering the methods of creation of stem cell memory products, the media used to maintain stem cell memory, and even composition of matter, where any product with more than 25% stem cell memory is covered by our patents. As I mentioned earlier, this results in the ability to do fully outpatient dosing. And we believe this is very important to expand the commercial reach of CAR T in general. Right now, most of our competitors are seeing very high rates of CRS and often high rates of neurotoxicity and high rates of admission to the hospital and the ICU. This is, of course, a very large safety issue for the patient, but also it turns out to be a cost issue, because if the patient needs to go into the ICU, oftentimes the cost of treating the toxicities can exceed the cost of the CAR T drug itself. Furthermore, some of our competitors are dosing almost every single patient with other drugs to try to mitigate the toxicity of their product, which further adds to the cost. Lastly, on the far right column, the great amount of cost reduction that could be obtained with allogeneic is only fully realized if you can make hundreds of doses from a single manufacturing run from a single healthy donor. By inventing the booster molecule, Poseida is able to achieve this and bring the cost of CAR T down to just a few $1,000s per dose, which between the cost savings and the toxicity advantages, this creates wide commercial reach and commercial viability for our CAR T products. The next slide shows you a summary of the results of our phase 1 clinical trial for BCMA 101, our autologous CAR T product. And on the left, you can see that we have very low rates of CRS. And even when we get to extremely high doses at the far right of the slide for our fifth cohort, we are seeing low rates of CRS. And again, we've never had a patient who needed to be admitted to the ICU. Despite this, we are seeing very good efficacy. So the key takeaway points from our myeloma program to date is that stem cell memory is a very important trait that we would want to maintain both in our autologous products but also our fully allogeneic products, because it enables fully outpatient dosing and much better tolerability. But it also addresses the cost barrier of CAR T. And on the next slide 15, you can see that in a subset of patients, we can get truly impressive long-term durable responses. The patient on the left, who we happen to know by name, Byron, because he got on a plane and flew cross-country to thank us for making the drug, he failed all standard CAR T therapeutics and also another anti-BCMA ADC therapeutic, then entered our clinical trial, was the first patient at our second cohort, and is now in over a 20-month durable response. The patient on the right, who we don't know their name, is one of our third cohort patients. And you can see that this patient is now in greater than an 18-month stringent CR. And importantly, we're showing you here the expansion curve for the CAR T cells in that patient's blood. And remarkably, this patient has detectable cells in the periphery past a year and a half. This is highly unusual in the CAR T space. Generally speaking, the more differentiated or maturated products will only show persistence for approximately 3 to 6 months. On the next slide, 16, I'm showing you the transition from the autologous product to the allogeneic product. And again, the key here for us is to try to maintain the TSCM or the stemness and all the desirable characteristics that go with that in a fully allogeneic product. And the way we do this is to keep most of the manufacturing steps the same. However, you can see as circled in red, we do add a single multiplex gene editing step on the front end of the process, which eliminates the expression of both MHC1, which addresses host versus graft disease. This is a persistence issue or a durability issue, and also eliminates the TCR, which can otherwise cause something called graft versus host disease, which can be a safety issue. We then add a related purification step to completely remove any cells that express TCR from the population, and typically we have final products that are over 99% TCR knockout. On slide 17, you can see that by removing the endogenous TCR, you can actually create a second problem, which is a yield or manufacturing issue. Most of the CAR T companies and academics who are making CAR T products will expand their product through the endogenous TCR. However, as I just mentioned, you need very high percent TCR knockout in your product in order to eliminate the graft versus host disease. Our product is typically over 99%, and so the question becomes, if you have over 99% of your cells without the endogenous TCR on its surface, how do you expand the cells? And the answer for us, without the booster molecule, and for most of our competitors, is that you simply cannot. This is shown on the right-hand panel in blue, showing the expansion or lack thereof of a product without the booster molecule. However, if you add the booster molecule, which is an RNA molecule that you add at the time of the addition of all the other nucleic acids on the front end of our manufacturing process, this will then encode transiently during manufacturing a cell surface protein that substitutes for this TCR complex and substitutes for the primary stimulation. This allows us to obtain hundreds of doses from a single manufacturing run, but yet maintain the stemness of the product. This is best demonstrated on slide 18. These are normal, healthy donors that are recallable and CMV negative who came in, and we manufactured them at near clinical scale. And we're showing the number of doses on the left-hand side of the slide at 150 million cell dose. And you can see that for our top donors, we're receiving hundreds of doses, so literally tens of billions of cells from a single manufacturing run. And on the right-hand side of the slide, despite this very high level of expansion, we're getting over 40% stem cell memory on average in our product. And when selecting for the top donors, we have upwards of 60 to 80% stem cell memory. Typically speaking, competitor products have less than 15% stem cell memory. Next, slide 19, you can see that we have taken on the left-hand panel an animal model of relapsed refractory multiple myeloma called RPMI, and we have titrated the stringency of this animal model to essentially have 100% positive predictive value. In other words, we've taken material from our BCMA 101 clinical trial with known outcomes and titrated the stringency of this model so that if you look at the patients in red that didn't respond very well with stable disease, they never are able to completely clear tumor in this animal model. If you look at the patients with good responses, such as VGPR and stringent CR, they are occasionally able to clear tumor. So we're sacrificing a little bit of negative predictive value. There are some patient materials that work just fine in the clinic, but at this high level of stringency cannot completely clear tumor. And the important point is shown on the right-hand side of the slide. Every single healthy donor that we've manufactured at near clinical scale and tested in this animal model clears tumor very well, and in most cases actually clears tumor better than our representative patient material that had a stringent CR in the clinic. On the next slide, 20, we further tested this in an additional model called MM1S. And this is a really interesting model for myeloma because like patients who are treated with anti-BCMA therapeutics, many times you'll get an initial response and then you'll see a relapse. And this allows you to test the ability to potentially redose. However, you can see that when we dose this animal model with either our autologous product, shown in left in red, or our fully allogeneic product, shown in green, we get an initial tumor control. We then see a number of animals that will relapse. However, without re-administering the product, we then get a second recontrol because the prodrug, the stem cells, when graft into the animal, will make an initial response. They remain engrafted and then will re-respond to any relapse. They then recontrol the tumor, and in the case of the allo product, those animals no longer have any detectable tumor and are essentially cured. You can see on the right-hand side of the slide, just like the patient I showed previously from the clinical trial, we have a very nice high Cmax of the CAR T cells expanding out from the bone marrow and the lymph nodes. We have a very wide area under the curve, and we have detectable cells all the way to the end of the experiment past 60 days. So in other words, the product is working exactly as designed, giving high levels of persistent cells, which result in very good efficacy and the ability to re-respond in this animal model. Now I'm going to move on to our solid tumor programs on slide 21. Generally, you may have heard that CAR T hasn't worked very well so far for our competitors in the solid tumor space. However, there have been a few exceptions to that rule where multiple high doses of CAR T has been administered. Unfortunately, generally that is not possible because you can't get enough cells to do that from a single manufacturing run. But in those few cases, some of our competitors have shown that you can actually get CRs, or complete responses, in several difficult-to-treat cancers, including glioblastoma multiforme and hepatocellular carcinoma. So even though there are possibly mechanisms that make solid tumors harder to kill than liquid tumors, such as checkpoint inhibitor, such as tumor hypoxia, these mechanisms can be potentially overcome by multiple rounds of high-dose CAR T. We believe that we can achieve that with the stem-like product with a single administration. And we've actually now shown this in several different animal models of solid tumors. The first one is shown on slide 22. This is a previously incurable animal model called LNCAP, which is a human castrate-resistant metastatic prostate line implanted in an immune-deficient animal. And you can see on the left-hand panel that both at a standard dose in orange of 10 million and what we call a stress test or low dose at 5 million in blue, we were able to get complete tumor elimination in every single animal. And that's shown both by BLI on the left and by caliper on the right. In the way that this works, very well demonstrated on the next slide, 23. You can see in the lower left panel that the stem cell memory, or TSCM cell population, is in the upper right quadrant. And as you go clockwise around, these are the more differentiated cells, or the drug. In the top row, you can see labeled MOC, where the cells do not interact with tumor. The product goes in. It's mostly stem cell memory with a little bit of central memory. As predicted, the central memory cells, which do not have the same desirable characteristics as stem cell memory, will eventually die, and you're left with an engrafted population of TSCM cells. These are cells that are just waiting around for something to do, waiting for a tumor to interact with. And in the case where we do have interaction with the tumor, shown in the bottom row, these cells will rapidly forward differentiate into all the different T cell subsets, and those will start killing the tumor. And you can see with the blue bracket labeled tumor elimination period, corresponding with the previous slide, these cells will start chipping away at the tumor until it is completely gone. And at that point, the more differentiated or maturated cells will die off, and you're left with an engrafted population or surveillance population of TSCM cells. It really is like a secondary vaccination against this tumor. The next slide, 24, shows you our very exciting MUC1C program. MUC1 you may have heard of because it's expressed on a lot of tumor cells, including breast, colorectal, and many others shown on the left-hand side. The problem with most approaches to treating or targeting MUC1 to date is shown in the upper right panel. A normal cell will have MUC1 cleaved, and there is a MUC1N molecule and a MUC1C molecule. To date, most other companies have tried to target the MUC1N molecule. Sometimes these are called TN binders, shown by the red arrow. However, unfortunately, as a tumor progresses, most of the cells will actually shed or lose the N-terminal piece. And so now you have a binder that, first of all, can cross-react with wild type, but also is targeting something that in many cases is not present on your target cell. We have binders called MUC1C, labeled in blue, which can actually recognize the little piece of protein that's remaining on the surface of the cell after MUC1N is shed. So on the bottom right panel, you can see that this binder in the context of a CAR T has very specific and robust killing against every cell line, every cancer line that we've tested to date, including pancreatic, breast, mesothelioma, non-small cell lung cancer, colorectal, and many others. But importantly, on the bottom right, you can see no on-target off-tumor, no cross-reactivity against wild-type epithelial cells or fibroblasts. So it's a very specific binder for the cancer form MUC1C. And on the next slide, 25, you can see very similar to the data that I showed with the LNCAP prostate model, in two difficult-to-treat animal models, triple-negative breast cancer on the left and ovarian cancer on the right, we were able to achieve 100% tumor elimination in every single animal, both at standard doses and at low doses. And likewise, we saw the exact same kinetics of our product. The stem cells go in, they engraft, they create your drug. The drug will chip away at the tumor until it's completely gone. Once the tumor is completely gone, the product will then contract back into a surveillance population of TSCM cells. And the last slide I'd like to show in the CAR T space, slide 26, which highlights our multi-target CAR T program. It's important to note, if you look at the left-hand panel, that most CAR T companies using the lentiviral technology or the gamma retrovirus technology have very limited cargo capacity and therefore use what's called a bispecific approach. They're sticking more than one binder on a single CAR molecule. There is increasing evidence that a multi-CAR approach using two fully functional CARs would be a better strategy, which we're showing on the bottom left-hand panel. And we can easily achieve that with piggyback because of its cargo capacity. In fact, if you look at the middle panel, you can see that we've shown proof of concept of delivering over 4 fully functional CAR molecules on the surface of the cell, which after positive selection is present on every cell in the population. Of course, we could deliver combinations of both CAR or TCR, which would eventually greatly expand the number of solid tumors that we can attack. And when you think about logic gating, the current approaches in the CAR T space are all OR switches. You're targeting a cell or a tumor that has target A or target B. Eventually, you would want to be able to target cells that have A and B or C. And to do that type of logic gating, you have to deliver fully functional CAR molecules. You simply can't do that with the lentivirus or gamma retrovirus technologies. It's fairly easy to do that with piggyback technology. Just as a reminder, the products that we're advancing right now in our pipeline are shown on the far right, which includes a CD19, CD20 dual CAR for B-cell leukemia lymphoma, a CD19 BCMA for a next-generation multiple myeloma therapeutic, and a dual allo pan-solid tumor, which is targeting MUC1C and an undisclosed second target. Now, transitioning over to our in vivo gene therapy program, these are the liver-directed in vivo gene therapy programs. Slide 28 shows you one of the major competitive advantages of our technology. The great majority of the other approaches in the current gene therapy space have transient therapies. So, for example, nanoparticles delivering RNA are very transient. AAV is a non-integrating system, and so it's a transient therapeutic. Unfortunately, the great majority of metabolic diseases manifest in the pediatric liver, and the pediatric liver is a rapidly dividing tissue, and therefore a non-integrating technology will get rapidly diluted and you will lose the expression of your therapeutic transgene. What I'm going to show is that with a combination of AAV and piggyback, or eventually nanoparticle and piggyback, you can get single treatment permanent integration, and that greatly increases the number of indications that one could treat with this technology. Our initial focus is on ornithine tricarbamylase deficiency and a second indication called methylmalonic acidemia, but there are numerous other pediatric liver diseases that we can treat, which others would have a very hard time addressing. You can see how this works on the next slide, 29. You could convert any AAV technology or adeno-associated virus into an AAV piggyback technology by simply adding as little as 50 nucleotide piggyback ITRs, or inverted terminal repeats, inside of the AAV ITRs. That converts the virus into AAV piggyback, but you still need to deliver the enzyme, the transposase. And on this slide, you can see on the left, if you just infect an animal with the AAV piggyback without the enzyme, what you see is a small number of hepatocytes showing persistent expression. And this is as a non-integrated episome. This is the same thing everyone has seen for the last 20 years in every standard AAV animal model, every standard AAV clinical trial. But in a juvenile liver, these will rapidly get diluted down to zero. Your transgene will be lost. However, on the right-hand side, if you simply add the transposase, you can get, in more than 80% of hepatocytes, permanent high-level transgene expression. You can see on the right-hand side of the slide, this has resulted in single treatment cures in multiple different animal models of disease, including ornithine tricarbamylase, citrullinemia type 1, where the gene is ASS1, and the bile acid transporter disease called PFIC3. For that last disease, PFIC3, our academic collaborators took the animals out past 2 years and showed high-level stable expression at greater than heterozygote or more than 50% of wild-type levels for the entire full life of the animal model. So again, single treatment cure. The next slide, 30, shows you how this works in an animal model of ornithine tricarbamylase deficiency. This animal model has absolutely no OTC enzyme expression, and so on the upper left panel, you can see that there is no expression of OTC in the liver, which would be normally seen by brown staining. If you simply add standard AAV therapy, you can see that just like for the previous slide, you get a small number of hepatocytes with persistent expression. However, if you switch to the piggyback system, you can get a 66-fold increase in number of hepatocytes expressing your transgene. And by eye, it's pretty apparent that this expression level is much higher than with AAV alone. That's actually quantified in the upper right-hand panel, where you can see the difference between AAV alone, which has subtherapeutic levels, and piggyback, which results in a 126-fold increase in expression levels, to actually go 10 times higher than wild type. Now, for this particular disease, one doesn't actually need supertherapeutic levels, which means we can decrease the viral titer and still get therapeutic efficacy. And that's an important factor because it's a safety issue and it's a manufacturing issue for AAV. You can see here on the bottom right panel that the difference between AAV alone and piggyback is the difference between 100% survival with the piggyback system and every single animal dying with AAV alone by 3 weeks. I mentioned earlier, if you go to slide 31, that the long-term goal is to do the exact same strategy, but delivering the piggyback system with a nanoparticle technology. We now have developed our own proprietary in-house nanoparticles that can either deliver the super piggyback RNA or the piggyback therapeutic transgene as DNA. In this case, we're showing you on the upper right panel that delivery of the therapeutic transgene alone, shown in red and labeled transposon only, will result in high-level initial expression, but in this juvenile model, where you do have rapidly dividing liver, that will eventually go down to the limit of detection. However, if you add the second nanoparticle, shown in blue and labeled transpose ACE plus transposon, you actually get an increase in expression level, which then stabilizes and persists out to the end of this experiment past 60 days. So very exciting, promising, long-term application here. And there are a couple big advantages that switching to nanoparticle gives you. Number one, you can go from the otherwise small cargo capacity of AAV to essentially the unlimited cargo capacity of piggyback, which now allows you to treat more indications. Also, the nanoparticle technology is not associated with immune reactions, meaning that you don't have to worry about patients that will have pre-existing immunity. And generally speaking, AAV itself is a single treatment therapy because you don't get the ability to redose. But with the nanoparticle system, you could theoretically redose. It also has a lot of manufacturing advantages. So to wrap up on slide 32, we have shown that we have extremely broad, extremely powerful platform technologies that allow us to do really anything both in ex vivo and in vivo gene therapies. We can create product after product with competitive advantages in the CAR T space, where we have both autologous and fully allogeneic products, and also in the in vivo liver-directed gene therapy space. But we can also generate additional value by out-licensing or partnering in other areas, such as shown on the slide on the top with iPSCs, hematopoietic stem cells, and regenerative medicine. This creates a very highly differentiated platform with multiple indications, multiple uses, with many future opportunities. Thank you for your time.